Thank you for joining, everyone. We're going to get started in one moment. Okay, great. We're going to get started. So hello, everyone, and welcome to our webinar addressing sleep and mental health. We're so glad that you've taken the time to join us live or via the recording. This event is brought to you by the Michigan Medicine Department of Psychiatry in collaboration with the University of Michigan Alumni Association. My name is Dr. Deirdre Conroy. I'm a clinical sleep psychologist in the Department of Psychiatry, and I'll be your moderator tonight. Tonight, we'll hear from 3 of our Michigan medicine experts who are active in sleep research and patient care, treating adults suffering from a variety of sleep disorders. They'll help us better understand the connection between sleep and mental health. Our speakers tonight will include Dr. Leslie Swanson, Dr. Greta Ragland, and Dr. Anita Shelgakar. I'm going to start by introducing each speaker. Dr. Leslie Swanson is Associate Professor of Psychiatry in the Sleep and Circadian Research Laboratory at the University of Michigan. As a clinical psychologist and diplomate in behavioral sleep medicine, her clinical practice centers on non-pharmacological interventions for insomnia and circadian rhythm sleep-wake disorders. Her innovative research portfolio explores the dynamic interplay between sleep, circadian rhythms, and mental health. Our next speaker is Dr. Greta Ragland. Dr. Ragland is a clinical psychologist and is also a diplomate in behavioral sleep medicine. She is a clinical associate professor at the University of Michigan Department of Psychiatry and sees patients in the behavioral sleep medicine clinic, as well as the perinatal and reproductive psychiatry clinics, and also participates in research in our sleep and circadian rhythm research laboratory. And last, but definitely not least, we have Dr. Anita Shelgakar. Dr. Shelgakar is professor of neurology at the University of Michigan Medical School, where she serves as program director for the University of Michigan Sleep Medicine Fellowship. Dr. Shelgakar completed her medical degree at Wayne State University, her neurology residency at Emory University, and sleep medicine fellowship at the University of Utah. She completed her master's in health professions education at the University of Michigan and has long-standing focus on medical education, particularly in competency-based education and assessment, as well as curriculum design and program evaluations. Dr. Shelgakar is currently president-elect of our American Academy of Sleep Medicine and is a past president of the American Academy of Sleep Medicine Foundation. Each of our presenters tonight will give a brief presentation. If you're watching this live, you can submit questions at any time using the Q&A feature at the bottom of your screen, and we'll pick some to discuss towards the end. We know that there may be many questions, so we'll likely combine some on the same topic, and please know that our experts tonight are unable to give you specific advice on individual situations that you might be facing. If you're unable to stay for the whole chat or would like to share this recording with a friend, you'll be able to watch this webinar again later via the Michigan Medicine YouTube channel. We're also sending the recording to all registrants along with the list of resources mentioned in today's webinar. So we're going to get started. Let's start with Dr. Swanson. Dr. Swanson, would you like to kick things off for us?
Absolutely. Thank you very much, Dr. Conroy. I'm going to share my screen so everyone can see my slides. And are you all seeing my slides? Actually, I'm not sure what's, okay, there it goes. Are you seeing my slides?
It's in, yes, now we are.
Okay, perfect. Well, I want to thank everyone for attending this Mind Matters presentation today. And I also want to thank the Department of Psychiatry and the Alumni Association for supporting and organizing the Mind Matters series. And a thank you to our other panelists and to Dr. Conroy for joining us today. And I'm very happy to be here today talking about one of my favorite topics and something we all hopefully do every night, which is sleep. And I'm going to focus my talk on understanding sleep, the fundamentals, and its impact on mental health. So as the first speaker, I'm going to introduce you to some sleep fundamentals and talk a bit about relationships between sleep and mental health. I'll kick things off by talking about the science of sleep, which can hopefully help you to understand the things that we do during the day and during the night that can impact our sleep. And then talk a bit about sleep and mental health. Before we start talking about science, I do have an old Irish proverb about sleep that I think sets the stage for us, which is that a good laugh and a long sleep are the two best cures for anything. So, what is sleep? It's an essential biological need. It's as important as food and water for humans. And it's a profound state of rest during which critical processes occur that ultimately rejuvenate us and it rejuvenates our body and our mind, and it gives us ultimately the energy to tackle a new day. Sleep occurs in several stages throughout the night, and they repeat throughout the night. And I'm going to walk us through the stages of sleep now. So we enter sleep into through a very light stage of sleep. Stage one sleep is a transitory sleep stage. And if someone woke you up out of this stage of sleep, you might say, I wasn't sleeping, I was just resting my eyes, because we don't perceive that we're asleep during this stage. It's very easy for us to be woken up by various, sorry, I'm moving my bar around here. It's very easy for us to be woken up by various stimuli during this stage of sleep. And it's something that we do for a small proportion of the night. And it lasts about 5 to 7 minutes on the initial cycle of sleep, which we'll talk more about in a minute. So stage two sleep is a bit deeper than stage one sleep, but it's still light sleep. And we perceive that we're asleep in stage two sleep. During this stage of sleep, our eye movements stop, our heart rate slows, and our brainwave activity starts to become slower. We spend about half the night in this stage of sleep. And then stages 3 and 4 are our deepest stages of sleep. During this time, during this stage of sleep, our brainwaves become very slow, and it's very hard for us to wake up from this stage of sleep. So if you've ever been woken during the night and you didn't know where you were or what was going on, you were likely awakened from deep sleep. And this is the stage of sleep where people might sleep through an alarm clock or a fire alarm. We spend the least amount of time during the night in this stage of sleep, and we get the most deep sleep in the first half of the night, which I'll show you a graph of what that looks like in a minute. And then the final stage of sleep that I'm going to speak about is rapid eye movement sleep. And this is also called REM sleep. And this stage of sleep is named after the rapid back and forth eye movements that occur throughout the stage of sleep. And this is the stage where most dreams occur. Interestingly, our brainwave activity looks very similar to what it looks like when we're awake during REM sleep. Our heart rate and our blood pressure increase during the stage of sleep, and they also look similar to what we experience during wakefulness. And we get the most REM sleep in the second half of the night. So, in a healthy individual, what happens is we go through the various stages of sleep in about 90-minute cycles throughout the night. So, what you're seeing here is a graph going from wakefulness down to the deepest stages of sleep. And then REM sleep or dream sleep are these blue bars here. And these are the hours of sleep across the night. And what we typically see is that we enter sleep from these light stages of sleep, and then we go into deep sleep. And then about 90 minutes later, we have our first cycle of REM sleep. And as you can see here, in a healthy individual, the deep sleep is front loaded in the first half of the night. And then we have dream sleep occurring more so in the second half of the night, closer to our final awakening for the day. And this may be in part to help us get ready for starting our day. Remember, REM sleep looks similar to wake in terms of what the brain and the body are doing during that time. But this also means that if you happen to wake up early one day for a social reason, or you just spontaneously wake up early one day, you might be missing out on REM sleep. And then the next night, your brain might try to catch up on REM sleep by making the REM period start earlier or lasting longer across the night. There There is a note to the graph that I just showed you, which is that how we go in and out of the different stages of sleep during the night and how much time we spend in each stage across the night can be influenced by many different factors. I have here the factors that most commonly impact our sleep architecture across the night. So these are things like age, our recent sleep history. Have you been sleep deprived? Have you been waking up too early some mornings? Are you going to bed late? Your circadian rhythms, temperature extremes can impact your sleep architecture, medications and substances such as alcohol, and sleep medical and psychiatric disorders. And as an example, alcohol can suppress REM sleep, and some psychiatric medications also decrease REM sleep. And Dr. Ragland later will talk more about how sleep architecture changes across the lifespan. Now that you know what sleep is, why do we do it? That's really an age old question that I think science is just starting to answer. We're learning that certain critical processes can only occur during sleep. And so, for deep sleep, for example, it's a time of restoration for our bodies and our brains. When we get deep sleep, our body repairs itself, our immune system is recharging itself, we're getting a break from stress hormones, we're balancing out our metabolic and growth hormones, and also we take out that kind of sleep helps us to take out the trash that's accumulated in our brain across the day. And for this reason, changes in deep sleep that occur with aging are implicated in brain diseases such as dementia. REM sleep or dream sleep, on the other hand, has a very different function. So during dream sleep, our brains are solidifying what we've learned that day and making links between new memories and old memories and processing emotional events. You can think about REM sleep as your brain's overnight workshop for sorting through things, softening things, and learning from things that have happened to you. By giving your mind the nightly emotional tune up, REM sleep helps you wake up better able to equip to handle whatever might come your way. Because REM sleep is so important in helping us to turn down the volume on emotional memories, it's implicated in psychiatric conditions such as post traumatic stress disorder, where we see that emotional memories remain highly charged over time. And nightmares, which are common in post traumatic stress disorder, might wake us up during dream sleep and lead us to have an incomplete REM cycle, which in turn can negatively impact emotional memory processing. Now, I'd like to talk about the two main processes that help you to feel sleepy at night and alert during the day. And they work together like teammates. And so here we see a typical day during which you're awake, and then a period of time when you're asleep here on this graph. And then we have wakefulness and sleep here. And the first process I want to talk about is called the sleep drive or sleep driver. And this is a process that works like an appetite. The longer you are awake, the more sleep drive you accumulate. The hungrier your brain is for sleep. And it's good for your brain to be pretty hungry for sleep at your bedtime. The second process, oops, I have to wait till those arrows go. So that's the sleep drive. And then as we sleep, that drive is met and that appetite is met and our hunger goes down for sleep. The second process is called controlled by your body clock, also called the circadian clock. And this system works by sending out an alerting signal to a greater or lesser degree, depending on where we are in the 24-hour day. It essentially tells your body when to feel alert and when to feel sleepy. So these two processes team up so that during the day, your circadian clock says, stay awake, even as your sleep hunger is building. That's why it's hard for you to just, most people, if you're healthy and well, to fall asleep at, say, 7 p.m. Hopefully, for most of us, it'd be hard for us to fall asleep right now. And that's because of the circadian clock that's telling you to stay awake, even though you have a lot of sleep hunger. At night, your circadian clock starts to say, hey, it's time to wind down, just as your brain is hungriest for sleep. And it does this in part by releasing melatonin, which is a hormone that makes us sleepy. And this usually starts about 2 hours before our bedtime but only if you're in dim light. Even relatively bright light can suppress your production of melatonin. One of the reasons why it can feel so bad to pull an all-nighter is that your brain is very hungry for sleep that next day, but our circadian clock is saying, nope, it's daytime, no sleep for you. And so then we feel wired, but in need of sleep. And in order to sleep well, we need these two teammates to be working together. So insomnia, jet lag, and other sleep disorders, which will be touched on later by Dr. Shelgakar, can occur when these two teammates are mismatched. A few notes now on the circadian clock. So again, this is a clock in our brains. It controls and organizes most of our biological functions throughout the day, including the time at which we fall asleep and when we wake naturally. And it's really important to know that it relies entirely on external cues from the environment to tell time. So to know if we should be awake or if we should be asleep, it's looking to the cues from the environment. And interestingly, most of us have clocks that run a little bit long. So most of us have a circadian clock that runs about 24 and a quarter hours. What this means, since we live on an Earth that rotates in a 24-hour cycle, is that we have to reset the clocks every day so that they match the 24-hour rotation of the Earth. And we do this through our environment and our behaviors. Remember, because the clock is taking in signals from the environment. And this graph shows you the most important, what we call zeitgebers or time givers to the clock. And we can all use these cues to help our clock running on time. They're listed in order of how strongly they influence the clock. So light and dark are by far the biggest time giver to the clock and telling the clock if we should be awake or if we should be asleep. But other things like exercise and meals and our social interactions are also important. And consistency in when these cues happen, especially around wake and bedtime, are especially important for our sleep. So just some take-home messages based on sleep science. So keep your brain hungry for sleep at bedtime and keep your clock running on time. So be careful about long naps, like naps that are longer than 30 minutes, and make sure that if you are napping, it's not too close to bed or wake time. Keep your time in bed schedule consistent so that you're waking up at the same time every morning. And don't sleep in too long on the weekends, and don't spend too much time in bed when you're not sleeping. Oops. Keep your days bright. So getting some sunlight in the morning and during the day is best, but indoor bright lights are okay too. Keep your nights dark. So dim light in the evening if you can, starting 2 hours before you go to bed, which also means that you have to be careful with light emitting devices at night, like phones, laptop screens, uh, iPads, things like that. Think about consistently timing your meals and your exercise when you can. And then be mindful of the things that can influence your sleep architecture, like alcohol use, caffeine use after noon, a bedroom that's too hot or too cold, or having an inconsistent sleep schedule. So now let's talk about sleep and mental health. First, I want to highlight that there's a very much a bidirectional relationship between sleep and mental health. So poor sleep can trigger or worsen mental health symptoms, but mental health struggles can in turn disrupt sleep. And this can end up in a vicious cycle with poor sleep and poor mental health feeding each other. Regardless of which comes first, we do know that sleep disorders are very common in psychiatric conditions. Here we can see the overlap between insomnia, which is in green, and sleep apnea, which is in blue, which is a common sleep disorder, and several mental health conditions, depression, post-traumatic stress disorder, and bipolar disorder, inter-episode, meaning not during mania or depression. And we see that insomnia is experienced by about more than half of individuals who are experiencing depression or bipolar disorder, even inter-episode, with rates of sleep apnea around 20 to 25% in these disorders. In contrast, we see that insomnia and sleep apnea are almost equally common in post-traumatic stress disorder. And it is interesting to note that this overlap between sleep apnea and post-traumatic stress disorder, given the potential role of REM sleep abnormalities in post-traumatic stress disorder, and that sleep apnea can really disrupt REM sleep. With respect to what science tells us about the role of sleep as a predictor for mental health conditions, I'm showing you some results from a study that looked at 19 different studies that pooled data from all these studies to look at whether insomnia is a risk factor for the new onset of a mental health condition. So these would be people who had insomnia first, but no prior history of a mental health disorder, and they were followed across time. And the results suggest that people who start out with insomnia are about 3 times more likely to have depression and anxiety. They're about 30% higher. They have a 30% higher risk for developing alcohol use disorders and a 25% higher chance of psychosis down the road. And if we look at all mental health disorders across the board, we find that insomnia more than doubles the risk, actually about 2.5 times greater risk for developing any mental health condition. So, in other words, these chronic sleep problems, they're not just a side effect of mental health conditions, they can also help us to predict who might be at risk for going on to develop a mental health condition. And it can be a warning sign. This also tells us that if you can address insomnia early on in the course, it might help stop depression or anxiety from developing later. Now, what I want to do is talk a little bit more about the bidirectional relationship between sleep and mental health. This, looking at data from a very large study, this was a study of about 15,000 adults that was focused on the chicken or egg question when it comes to insomnia and mental health. And what you're seeing here is for those people for whom the insomnia started before the mental health disorder, people for whom the insomnia and the mood disorder started together, and then in the green, people for whom the mental health condition preceded the insomnia. And we have mood disorders here, so depression and bipolar disorder. And what we're seeing with mood disorders is that the insomnia most commonly shows up first, and it's also a major harbinger of a recurrence for depression or a bipolar mood episode. For anxiety, though, what we're seeing here is that it's often the case that the anxiety disorder comes first and then the insomnia develops second, or they both happen at about the same time. And so I think this makes sense as we often think of insomnia as a disorder of high alert or high arousal, which we often also see in anxiety. Across mental health conditions, sleep data suggests that experiencing sleep disturbances can increase the risk for suicidal thoughts and behaviors. This is a study by Harris et al. That pooled results from 42 long-term studies that to see how sleep problems related to later suicidal ideation, suicide attempt, or death from suicide. And what they found is that insomnia had the strongest effects for risk for suicide thoughts and attempts and death. So it significantly predicted suicidal ideation as well as death from suicide. We also found that nightmares had an impact on the risk for a suicide attempt, and then more generally measured poor sleep quality or sleep problems were linked to more thoughts of suicide. And then when we study people in the lab, when we have people come and sleep in the lab and take a look at what their objective sleep looks like, we actually find that there are differences in their sleep relative to healthy people who don't have mental health conditions. And what we can see here is sleep fragmentation, actually, this should be sleep continuity is lower. So sleep is actually more fragmented, so less continuous sleep across these disorders. Sleep is less deep uh, across these disorders, with the exception of post-traumatic stress disorder. And then we also see some abnormalities in rapid eye movement sleep, something called more increased REM pressure, so more dense REM or dysregulated REM that's occurring in affective disorders, depression, anxiety disorders, and post-traumatic stress disorders. So objectively, we are seeing that there are measurable changes in how the brain cycles through sleep in mental disorders. And finally, I'm going to wrap us up with hopefully what's a bit of good news, which is that treating sleep problems can have powerful and positive impacts on mental health. So this was a study that pooled results from more than 20 studies. And this was looking at the gold standard insomnia treatment called cognitive behavioral therapy for insomnia. And they were looking at what happened to people who had mental health conditions who did this cognitive behavioral therapy for insomnia. And we found that this treatment had a moderate improvement for depression, a very large improvement for post-traumatic stress disorder, a large improvement for alcohol use disorder. And then in studies that had multiple mental health conditions included, again, a moderate to large improvement after treating insomnia. So I think what these data suggest is that not only is getting your sleep back on track going to help you to feel more rested, it can also meaningfully improve symptoms across multiple mental health disorders. And this slide shows similar results from another a study of studies. This was a study that pooled results from more than 72 studies. And what these results show is that any type of sleep treatment, so this was sort of generically defined sleep treatment, has a moderate and positive effect on uh, mental health symptoms really across the board here, including some of these symptoms: rumination, stress that often accompany anxiety, as well as psychosis. So I think this provides further support for the positive impact of treating sleep problems on mental health, even considering aspects of mental health beyond disorders. So I'm going to summarize now that obviously sleep is an essential function for all of us, just like our need for food and water. Sleep is made up of different stages throughout the night, and these stages of sleep serve different purposes. Sleep is controlled by two processes in the brain, and we need both of those things to be working together as good teammates in order to sleep well. Sleep is closely linked to mental health, and improving sleep can lead to better mental health. And with that, I will stop my sharing and I'll hand it back over to Dr. Conroy.
Thank you so much, Dr. Swanson. That was fantastic. And now I would like to introduce Dr. Greta Ragland, who will provide our next presentation. Welcome back, Dr. Ragland.
Thanks, Dr. Conroy. Hi, everyone. Thank you so much for being here. Give me just a moment to pull my screen up for you all so that you can see what I am seeing. So Dr. Swanson did such a fantastic job introducing us to the impacts of sleep disturbance on mental health and vice versa. And I'm going to be talking a little bit more about normative sleep across the lifespan, what we would expect sleep to look like for individuals at various stages of life, and how we can kind of manage sleep and keep our sleep good quality in spite of some of these changes across the lifespan. So we're going to be looking at specific changes in sleep across the lifespan, challenges for different stages of lifespan sleep, and then how we define good sleep, and then again, how we can maintain good quality sleep across the lifespan.
And you can change it to presenter mode, Dr. Ragland.
Thank you very much for letting me know that that was not on. Hang on one second. Is it not showing up on your side?
Slides were okay. It was just we saw your next slides going. There you go.
Okay. Give me just one second, and I apologize for this. We had trouble, hadn't done troubleshooting on this before, but it looks like on my side now I am not seeing the presenter view. Are you seeing just the slide at this point?
Yep, I can see your full slide now.
Okay, excellent. Thank you so much. So our gold standard for measuring the various stages of sleep that Dr. Swanson was talking about is through polysomnography or PSG testing. And Dr. Shelgakar is going to talk about this a little bit more in her presentation. But this allows us to gather information from lots of body cues, including brain waves, muscle tension, eye movements, limb movements, heart rate, and breathing patterns. And sleep can also be measured in addition to PSG testing through at-home sleep studies, which some some of you may have experienced, or even through wearable devices like watches or rings. I just want to make one note on some of the wearable devices. They can give us reasonable estimates about kind of your sleep timing. So if you're using a wearable device, that can be somewhat accurate, but they're not typically advanced enough to give us much reliable measure of sleep staging. So don't panic if your Fitbit tells you you're not getting enough REM sleep. Typically, that's not as accurate as the testing that we're able to do in the lab. And as Dr. Swanson mentioned, we are typically moving through our night of sleep in stages or cycles of 90 to 120 minutes, where we're going through all of the various stages of sleep, from light sleep to deep sleep and into dream or REM sleep. What's important to note, though, is that sleep can look really different at different stages of life, based both on age and development. And that sleep can also vary night to night, even within a single individual, depending on various factors like what they've been doing during the day, what their sleep looked like the previous night, or whether they have any specific disruptions over the course of the night. And when we're thinking about kind of general changes in sleep across the lifespan, we see that babies tend to sleep more than adults, which I think we can probably all intuit. And as we age, we tend to spend more of our 24-hour day awake, less time asleep in total, and less time in REM sleep, or that dream sleep that Dr. Swanson was talking about. It's also important to note, and we'll talk a little bit more about this, that as we age, we tend to have more disruptions in our night of sleep as a natural element of our changing bodies. So this is an example of sleep architecture in healthy individuals. So this top chart here shows us what sleep looks like in a younger adult, while the bottom chart shows us what it might look like for an older person. And so we can see that there are these kind of gradual steps down into deep sleep. REM sleep is concentrated in the second half of the night, and there are few episodes of awakening for the younger adult. Now, in the older adult pattern, we do see less of that deep sleep, less REM sleep, and it's more broken up or more fragmented, and more periods of wakefulness across the night. And so these are kind of the three general changes that we see between young adults and older adults. There's less deep sleep, less REM sleep, and more fragmentation throughout the night. The other thing that we find that changes across the lifespan is, again, that the average amount of sleep that an individual gets across the lifespan decreases. For those of you who spend any time with babies, you'll know how unproductive we would all be if we slept like babies. And so as we discuss each of these developmental changes, we'll talk about kind of how much sleep we would expect in these various stages of life. But I also want you to keep in mind that these are averages and that they're pretty broad ranges for each stage of sleep. And so as you're thinking about kind of normative sleep and what your sleep should look like, just remember that there's no right amount of sleep for any given individual. And you don't need to be alarmed if you are a short sleeper or a long sleeper. Those can both be normal parts of sleep. So I'm going to start just by talking about what we expect in the first year of life. So again, infants get the most sleep of all of us. They're usually sleeping anywhere from 12 to 17 hours per day. This is likely because of the extent to which their bodies and brains are rapidly growing and developing. And young babies tend to have more irregular sleep schedules, more daytime sleep, and they don't necessarily adhere to our 24-hour day, as most parents can attest. The other interesting thing about infant sleep is that they have a lot more REM sleep. So they're spending a lot more time in dream sleep. Up to 50% of their night is in REM sleep. And this is really critical, we believe, for brain development for infants. And so infant sleep is not something that's sustainable over the course of our whole life. And even into toddlerhood, our sleep begins to consolidate across the day. So it becomes more concentrated at nighttime, and somewhere between the ages of 2 and 4, children usually stop napping during the day and begin to achieve their full dose of sleep at nighttime. They're also beginning to shift away from that high concentration of REM sleep, and they have more consistent sleep and wake patterns, fortunately. Now, as we approach adolescence, sleep changes once again. And so while the sleep need for adolescents tends to decrease somewhat, adolescents are often accused of needing a lot more sleep. And part of the reason for that is likely because they experience a natural shift in their circadian preferences that leads them to have kind of a natural drive to stay up later and wake up later than previously. Now, this isn't every adolescent, but it's pretty common in this age group. So this combined with kind of the social expectations that they're going to be at school first thing in the morning may lead them to get less sleep than they need, and also might leave them feeling sleepier in the morning because they're kind of off of their natural rhythm. Adolescents are also prone to overuse of technology, especially in the hours prior to bed. And as Dr. Swanson noted, this can further delay their bedtime and kind of decrease their sleep quality. So you can see in the context of a conversation around mental health, how this age group might be particularly susceptible to sleep negatively impacting their overall well-being. If they are experiencing this biological shift in their sleep timing and they're experiencing a tendency to have less sleep, therefore, than they need, they may actually find themselves more sleep deprived than you would expect, given how long they might sleep in on the weekend. And this can make them at higher risk of certain effects of sleep deprivation, or may exaggerate mental health diagnoses that they're already experiencing. Now, in adulthood, sleep typically reaches a degree of rhythmicity with our lives, and we find kind of our natural sleep cycle, our sleep rhythm. We're usually sleeping somewhere between 7 and 9 hours of sleep during adulthood. But remember, this is an average and not necessarily what your sleep is going to look like. I do want to highlight, however, that there are a lot of factors that can negatively impact our sleep during adulthood. So, in particular, adults are more likely to experience certain sleep disorders, things like insomnia, sleep apnea, and restless leg syndrome that Dr. Shelgakar will talk about more in her presentation. And adults may have work or social commitments that don't align with their innate circadian rhythm that lead them to have more difficulty with sleep timing or leading to sleep deprivation. This is particularly the case for folks who are doing shift work or who have multiple jobs that lead them to have unusual sleep timing. Or who have little children who are up frequently over the course of the night. And then there are also a lot of stressors that arise during adulthood, including work challenges, parenting responsibility, caretaking roles. And each of these and other stressors and responsibilities can negatively impact adult sleep and also can negatively impact adult mental health. And so we can imagine how sort of the confluence of these various stressors, along with possible sleep disruption, may lead people to have kind of that multi-directional effect that Dr. Swanson was discussing. So before stepping into the next stage of development, which would be older adulthood, I would like to highlight two specific areas of challenge for adult sleep. And these I'll just touch on briefly. And this is because we did have several questions coming in about these in advance of the presentation. So one of these is the transition to parenthood, and the other is menopause. So pregnancy and parenthood can contribute to significant changes in sleep patterns for both birthing parents and those who do not deliver babies, but are part of their caregiving community. So pregnancy and its related hormonal and bodily changes can lead to a lot of sleep disruptions that can be perpetuated postpartum through overnight feeds, babies' irregular schedules, healing from delivery. And so one of the biggest factors that can impact, in particular, a postpartum mother's mood and mental health is sleep. So getting enough sleep, getting adequate sleep, and getting good quality sleep are all really, really important for helping a new parent to heal appropriately and adjust to their role as a parent. And so our recommendations are to really utilize teamwork and support systems in order to ensure that new parents get at least 4 hours of consecutive sleep that is uninterrupted each night. This can be really tough, but using family, friends, or nighttime care services can really help if that's available. We also really encourage new parents to maintain light exposure during the day and keep keep lights as dim as possible overnight, especially when doing feeding or taking care of baby overnight. This can actually help both the parents to kind of maintain the rhythmicity of their sleep and also help their babies begin to achieve a 24-hour rhythm in their sleep. And so these are really just a couple suggestions for maintaining good quality sleep in the postpartum or transition to parenthood era. And there are a lot of other suggestions that we could talk about, but I think that this is a good starting point and also a good starting point for folks when considering how to maintain their overall wellness and mental well-being in this difficult transition. Now, speaking specifically to menopause and sleep, we have many studies that demonstrate that menopause can lead to significant disruptions in normal sleep patterns. And these are typically attributed to vasomotor symptoms of menopause, which include hot flashes and night sweats, which can be very uncomfortable overnight. But we do find that sleep disturbance is often present even in the absence of those vasomotor symptoms. So it's clear that there's something else going on besides just night sweats that's leading to this disruption in sleep. And there's also during this time period an increase in certain mental health symptoms, especially around depression and anxiety. And typically, we are associating these changes with the hormonal fluctuations and variability that can happen during the menopausal transition. Importantly, there are other sleep disorders besides just insomnia that can crop up during this period, including restless leg symptoms, sleep apnea, and hypersomnia. And all of these can happen not just at the actual point of menopause, but during the entire perimenopausal transition. So this can be something that folks are dealing with for a very long time. So optimizing sleep behaviors can assist with some of these symptoms. So we'll talk a little bit more about kind of general behaviors for maintaining good quality sleep. But even with really good sleep behaviors and sleep habits, some people will still experience disruptions in their sleep during the menopausal transition. It may also be helpful to discuss the use of hormone replacement therapy and or melatonin with your medical providers, as there is some evidence to support both of these as being helpful with menopause-related sleep disturbance. So moving into older adulthood as promised, it's notable that sleep need may decline during this phase. Now, keep in mind that the general recommended amount of sleep is still somewhere between 7 and 8 hours, but that range gets a little bit wider, and there are more individuals who need less sleep during this phase. This should therefore not necessarily be interpreted as problematic if a person begins to experience less sleep overnight, as long as they continue to feel well rested during the day. Older adults may also, like we discussed previously, experience lighter, more fragmented sleep that might make them feel like their sleep quality is poorer. But again, as long as they're feeling well rested and like they got adequate sleep, there's nothing obviously concerning about this. So as we age, we also have a tendency toward kind of another circadian shift opposite from what we experience usually in adolescence. And this is an advanced sleep phase where we tend to be more likely to go to bed early and wake up early, which can lead to increased sleepiness in the evening, as well as early morning awakenings, which can be bothersome for some individuals. Sleep disorders that were present in younger adulthood can become even more prevalent with age. So again, the kinds of sleep disorders that Dr. Shelgakar is going to talk about can come up in older adulthood. It's also important to remember that in older adulthood, there are some indications that folks tend to get less exposure to bright light and outdoor light, as well as less social exposure in some cases. And so there can be challenges with circadian rhythm and sleep that are more dependent on some of these social or environmental factors. So I want to talk briefly about what we mean by good sleep or good quality sleep. And this is something that comes up really often when we're talking with individuals who are concerned that they might not be getting good enough sleep. So when we talk about good enough sleep, we're really trying to make sure that people feel like they're getting adequate rest and that they're able to attend to their activities of daily life without excessive fatigue. So the tendency to doze off during sedentary activities like watching TV or reading a book are not a normal part of age-related sleep changes. Certainly, drowsiness while driving is not a normal part of our age-related sleep changes, and these are symptoms that we would consider abnormal for aging. So if you're experiencing excessive drowsiness or sleepiness during the day, this would be a reason to contact your providers or discuss your sleep quality with a doctor. It may be that there is an underlying sleep disorder or another medical condition that's contributing to that excessive sleepiness. So even if your sleep doesn't seem perfect to you, as long as you're feeling well rested, it might be good enough sleep. So when we think about maintaining sleep across the lifespan, the recommendations are pretty much the same for everyone. We want to work on maintaining consistent sleep and wake schedules, as this gives our body good cues for our circadian rhythm. Keeping light bright during the day and dim in the evening, like Dr. Swanson mentioned, helps our bodies to keep cued up to the natural cycle of the earth. Avoiding electronics and stimulating activities right before bed can help us to settle our brains and our bodies for sleep. Keeping meal times consistent and avoiding large meals right before bed helps our body again get ready for sleep. And avoiding substances that can interfere with sleep, especially close to bedtime. We know that all substances like cannabis, alcohol, caffeine, and nicotine can negatively impact the quality of the sleep that we're getting. And so regular use of these substances should be kept away from bedtime or ceased if possible. And we really recommend engaging in physical activity at all stages of life. This is great for your mental health, your overall health, and also for your sleep health. So to the extent that your body is able to, continue to engage in physical activity. Another recommendation is to keep bed for sleep and sex only. This allows your body to develop a good impression of bed and kind of an association that bed is really meant for rest, so that you're less likely to feel that need to work through all of the different thoughts that come up when you get into bed. So maintaining that as kind of a sacred spot is really helpful for keeping your sleep good quality over the course of your lifespan. And just in summary, sleep changes in duration and quality across the lifespan. Every person has different sleep needs. Different life phases present unique sleep challenges, and it is possible to sleep well at all life stages. But I want you to all to remember that just because your sleep doesn't appear to be perfect doesn't necessarily mean that it's bad sleep, as long as you're feeling well rested during the day. And with that, I'm going to pass it back to Dr. Conroy.
Great. Thank you so much, Dr. Ragland. That was great. So our next presenter is Dr. Anita Shalgakar, and she will be providing the last presentation before we go to questions. And please remember to use the Q&A if you have any questions. To you, Dr. Shalgakar.
Great. Thanks so much, Dr. Conroy. And let me just pull up my slides here. Okay, so I'm going to be talking about other considerations for your sleep and giving a quick overview of other sleep disorders. So just a disclosure, as was mentioned earlier, I'm on the board of directors for the American Academy of Sleep Medicine. I've created this presentation in my own personal capacity, and so these views are mine, not necessarily speaking on behalf of the AASM. And any unattributed images you see in my presentation are available under a Creative Commons license. So let's talk a little bit more about what's up next. So we're going to talk about recognizing disordered sleep and what concerns to raise with a provider in a healthcare setting if you do have concerns about your sleep, and then also strategies to prioritize healthy sleep. All right, so some common sleep disorders, and we'll do a very quick overview of all of these, are circadian rhythm sleep-wake disorders, central disorders of excessive sleepiness, otherwise known as central disorders of hypersomnia, restless leg syndrome, insomnia disorder, and then obstructive sleep apnea, abbreviated as OSA. So if you're concerned that you may have a sleep disorder, then we encourage you to seek evaluation with your primary care provider and possibly even a sleep medicine specialist. And we'll go through some of the symptoms that are suggestive of these disorders. So we'll start with circadian misalignment. So you heard from Dr. Swanson about our internal clock and how that regulates our interaction with the world around us. So that circadian phase or internal clock can be shifted in one direction or another. So when it is delayed, that means the internal clock is late compared to the external day and night. So that means that bedtimes and wake up times are later than what's considered to be socially acceptable or conventional sleep-wake times. On the other hand, when there's a circadian phase advance, that's when the internal clock is set early compared to the external environment. So that means an individual's bedtimes and wake up times are earlier than socially acceptable or conventional times. These are things that are inherent to a person's circadian phase, so we call them intrinsic circadian disruptions, but there are things that are extrinsic as well that are kind of superimposed and not inherent to somebody's biology. So one example of that is shift work. So that's when somebody is working kind of out of sync from their preferred timing based on their internal clock. So shift work happens when at least a portion of the shift occurs between 7 p.m. and 6 a.m. And so that can be a late worker or someone who's working early. And then again, the internal clock is shifted in either direction depending on the timing of the work shift, but the internal clock is shifted either early or late compared to the external world. And that again can cause a misalignment between the internal clock and the external environment. And then finally, jet lag, which occurs in the setting of really quick transitions across time zones during travel. And so again, that disruption can be either a phase delay, so being late compared to when the internal clock is late compared to the external world, or it can be a phase advance when the internal clock is shifted earlier than the external world, depending on whether you are traveling west or east. We have central disorders of excessive sleepiness, otherwise known as central disorders of hypersomnolence. And the primary concern with this category of disorders is daytime sleepiness. And specifically, it's daytime sleepiness that is not due to disturbed nocturnal sleep and not due to the circadian misalignment that we just reviewed. So separate from these other contributors that may cause excessive sleepiness. If other sleep disorders do exist, then they need to be fully treated and kind of taken off the table before you can really truly consider yet another sleep disorder in this category of central disorders of excessive sleepiness. And the daytime sleepiness must exist for at least 3 months. So it's not a short-lived sleepiness, but a more extensive sleepiness that again isn't due to other obvious factors in order to render this diagnosis. And these include diagnoses such as narcolepsy and idiopathic hypersomnia. If these disorders are suspected, then there is diagnostic testing that we pursue in order to confirm and solidify which diagnosis we think is the most appropriate one for a given individual. Then there's restless leg syndrome, which is classified by an overwhelming urge to move the legs that's accompanied by an uncomfortable or unpleasant sensation in the legs. And in particular, these uncomfortable sensations begin or worsen during periods of prolonged inactivity or rest. They do improve with leg movement, and they occur either exclusively or predominantly in the evening or night. Sometimes when people have had restless leg syndrome for a very long time, the symptoms may start to occur earlier in the day, but when we think about the onset of symptoms when they first began, there really is a circadian component to it, and there really does seem to be a distribution closer to the evening and nighttime hours. In addition, these symptoms are not accounted for as symptoms of another comorbid disorder, either behavioral or medical condition. And these symptoms are distressing to the patient. So there's not a sleep lab test that we do separate from some of the other disorders that we treat and manage, but this is really what we call a clinical diagnosis. So we're really relying on the patient's description of these symptoms and their descriptions of how distressing these symptoms are to their day-to-day lives in order to make a diagnosis of restless leg syndrome and to consider any type of treatment at that point. And then we have insomnia disorder, which is a collection of disorders that are classified by a number of symptoms. So first, one or more of the following: difficulty initiating sleep, so difficulty falling asleep, or difficulty maintaining sleep, difficulty staying asleep, waking up earlier than desired, having a resistance to going to bed on an appropriate schedule. So you can think about that if there are younger patients, or difficulty sleeping without parent or caregiver intervention. So again, often related to children. And then one or more of the following, which is fatigue or malaise, impaired concentration, memory, or attention, impaired social, familial, occupational, or academic performance, mood disturbance or irritability, daytime sleepiness, behavioral problems, reduced motivation, energy, or feelings of wanting to take initiative, having a proneness for errors or accidents, and concerns with dissatisfaction about sleep. So just feeling unsatisfied about the quality or duration of sleep. And as we've kind of talked about with other sleep disorders, these symptoms aren't better explained by something else. So they're not better explained by just inadequate opportunity to sleep. Sometimes we see people who may be holding down 2 jobs and then have caregiver responsibilities, and there simply aren't enough hours in the day to shut their eyes and get enough sleep. But that we wouldn't classify that as insomnia disorder, because we would try to address those factors differently. In addition, the sleep disturbance and the associated daytime symptoms occur at least 3 times per week. And these sleep-wake difficulties, again, are not better explained by another factor or another sleep disorder. When these types of symptoms have been present for less than 3 months, we consider that to be a short-term insomnia disorder. When they've been present for at least 3 months, then we consider that to be chronic insomnia disorder. So then what about sleep medications? Just wanted to touch on these very briefly. Prescription sleep medications are indicated for acute or short-term insomnia, but we really take a critical eye to this when we think about this and really try to make decisions on a person-by-person basis. We think about the side effects of the medication. We think about the worry for dependence or tolerance. We think about vulnerable populations. So if someone has a risk of falls, for example, if someone is on a number of other medications and they're maybe concerned about medication interactions that may ultimately do more harm than good. So there are many factors to think about when considering the initiation of a sleep medication to get over a short-term bout of insomnia. The over-the-counter sleep aids have mixed scientific support. There's not one that we can just readily say, oh, aha, yep, that's it. That's definitely the one you should consider. So again, kind of depends on what the other comorbid concerns are for a given individual to consider, is there an over-the-counter sleep aid that may make sense at a given time. Then cognitive behavioral therapy for insomnia is the first-line treatment for chronic insomnia disorder in adults. But if that's not available, if that's not feasible for a variety of reasons, then there may be appropriate consideration of short-term hypnotic use, short-term medication use. But again, that's something to consider on a person-by-person basis. And so we really do encourage people to talk with their primary care provider or sleep medicine specialist if this is a consideration that would merit further discussion. And then finally wanted to talk about obstructive sleep apnea. I have a cartoon here, which I think resonates with a lot of people. So it says, I'm the apnea fairy. I have orders to give you a wake-up call at 10:30, 10:47, 10:53, 11:02, 11:17, 11:26. And this, I think, is reflective of the experience of many of our patients who have obstructive sleep apnea that's untreated. So some of those symptoms include breathing pauses, snoring, gasping or choking during sleep, the need to get up to urinate during the sleep period, fragmented or very choppy sleep. Even though time may be spent in bed, the total sleep time is reduced because of these repeated awakenings due to the disruptions in breathing. And then the sleep is non-refreshing, it's non-restorative. So despite the number of hours in bed, people wake up feeling really quite tired and not refreshed. There can also be a whole constellation of daytime symptoms as well, such as morning headaches, decreased concentration, memory loss, decreased libido, irritability, and excessive sleepiness that again is not explained by other factors or other medications or other medical conditions. So if there is a concern for obstructive sleep apnea, then either in laboratory testing at a sleep facility or a home sleep apnea test is needed to confirm that suspicion and to confirm the diagnosis of obstructive sleep apnea. So if that's something that you are concerned about, or for yourself or a bed partner or a family member, then talking to a healthcare professional about pursuing the diagnostic testing would be the next best step. The most common and first-line treatment for obstructive sleep apnea in adults is continuous positive airway pressure, otherwise known as CPAP. And we have a picture of it here. So this is an air blower. It takes regular room air and delivers it at a higher pressure. So it's not supplemental oxygen. It's the same concentration of oxygen as the room air that we breathe, but it's delivered at a higher pressure. It's kind of like turning up the faucet. And having a higher pressure delivery. And so that higher pressure comes through the tube here, which is connected to the mask. And that higher level of pressurized air helps keep the airway open so that it's not having those repeated interruptions from breathing. There are other treatments for obstructive sleep apnea as well. Weight management for some people can be a very useful additional or adjunctive treatment for obstructive sleep apnea, using either medical and or surgical approaches to improve nasal breathing if there is an obstruction in the nose or the nasal airway. Positional therapy, which is preferentially sleeping in one position. Sometimes people have worsened sleep apnea when they sleep on their back compared to sleeping on their side. So we will sometimes prescribe that as part of the treatment plan to avoid back sleeping. There are oral appliances that dentists can custom make for the mouth in order to pull the lower jaw forward in an intent to open up the airway that way. So rather than using the pressurized air, it's using the mechanics of moving the jaw forward to pull the connected tissues forward and open up the airway that way. There is recently an FDA-approved medication for treatment of moderate to severe obstructive sleep apnea in appropriate individuals. So that's relatively new in our toolkit to use for obstructive sleep apnea. There's hypoglossal nerve stimulation. The trade name is Inspire, the Inspire device. That is a surgically implanted device that can be considered in appropriate individuals for treatment of obstructive sleep apnea. And there are other upper airway surgeries as well that have to do with surgery related to the position and attachment of the tongue and some of the other bones and soft tissues in the upper airway. One caveat about these other obstructive sleep apnea treatments is that they have specific criteria oftentimes. And so there's not a one size fits all approach. If you're considering not using CPAP or using CPAP in addition to one of these treatment options, then it's really important to see somebody who can talk you through these, talk through your candidacy, what's the appropriateness of different types of treatments for sleep apnea, what are other considerations in light of other cardiac concerns or medication concerns, again, to make sure that you proceed as safely and effectively as possible. So that's a lot of information. So in light of that, are there any high yield tips? And I think some of this will overlap with what Dr. Ragland presented, but just to prioritize, to talk about healthy sleep, first is to know your sleep needs. And how do I do that? Well, you've seen a different version of this diagram over the course of this presentation, but I'll skip forward to this to show you. If you go to the website sleepeducation.org, there's a bedtime calculator, and you can put in your age, and it will use the science and the recommendations once you put in your wake up time to tell you what your bedtime should be, again, based on normative data, population data, to give you an estimate of when that bedtime should be. But as you know, sleep needs are also individual. So even all the same people living under the same roof may have different individual biological needs for sleep. So understanding how much sleep you need on a regular basis to wake up and feel rested and alert. And we can accumulate a sleep debt if night over night we're not getting enough sleep, but then we can accumulate that debt or that deficit depend, and there can be a number of factors that may cause us to lose sleep, but that's something to think about in addition to kind of what our basal sleep needs are. So it's important then to get enough sleep when we're not living life, when we're not working, we're not socializing, we're not traveling. And some ways to do that are, again, consistency is key. The brain really loves consistency, consistent bedtimes, consistent wake up times. You've heard a lot throughout this presentation about the benefits of a healthy night's sleep and prioritizing your sleep, using reminders to tell you when to wind down, using alarms to help contain or maintain that consistent wake up time can really help you establish a healthy and restful routine. And then if you do need to play catch up because you've accumulated a sleep debt, then just think about adding no more than 1 to 2 hours. Sometimes if you add on a lot of sleep after a long period of sleep deprivation, it may make it harder to go to bed on time the next night, as Dr. Swanson had told us about our sleep pressure, our sleep hunger. So you want to try to keep that in check. So again, consistency is key to really try to avoid those big, massive swings in the amount of sleep you're getting night to night. Caffeine can be a very helpful alerting agent, specifically if it's used early closer to when you wake up rather than closer to when you go to sleep. And actually having low repeated doses of caffeine may be most effective rather than having just a quick shot of caffeine really quickly. The caveat to this is to know yourself, know your comorbid conditions, and know your medications. If there are concerns about interactions, if there are concerns about palpitations or high blood pressure or getting jittery or anxious, everybody metabolizes caffeine differently. And so, think about this in the right dose at the right time for each individual person. And then finally, reach out. So contact your primary care provider or sleep medicine specialist. If you've tried behavioral strategies and you still struggle to get a good night's sleep, you've been getting enough sleep. You've been logging the hours and you just don't feel rested when you wake up. You have questions about using your CPAP or other obstructive sleep apnea therapies, or you have concerns about mood issues and sleep. Any one of these are reasons to reach out and see if you need a more specific sleep evaluation. And again, here's that website, sleepeducation.org. They have a number of resources. It's hosted by the American Academy of Sleep Medicine, a number of patient-facing resources. You can find accredited sleep centers there, and they have resources for people of all ages. So I hope that is useful for you, and I will turn it back to Dr. Conroy.
Thank you so much, Dr. Shelgakar. So these presentations have been wonderful, and all of you have had some great questions coming into the chat and in the Q&A. So we'll be moving on to your questions. And we know that many of you have already submitted questions during the registration process. If any other questions have occurred to you during the presentation, go ahead. If you haven't already, submit them using Q&A at the bottom of your screen. If there's a specific person you'd like to direct your question to, please also include that. Again, the speakers are Dr. Swanson, Ragland, and Shelgakar. So what I'm going to do is I'm going to start with some of the the questions that were submitted before the presentation. And what we're going to do is I'm going to lump them into certain categories and identify a speaker to try to help us answer these questions. And then I'll try to get to the Q&A questions that have come in. One major topic that did come through is the question of women's sleep, particularly in the menopausal transition. I'm going to read some examples of these questions, and then we will spend just a couple minutes on each topic. So starting off with the topic of women's sleep and menopause, some questions include a discussion of hormone balancing for women going through menopause and how to regulate for better sleep would be helpful. How does sleep deprivation affect the postpartum experience? Or as women age, sleep patterns seem to change, giving us interrupted sleep nightly. Prevention tips? And for these questions, I'm going to ask Dr. Ragland to take a stab at those.
Thanks, Dr. Conroy. Happy to step in on this. These are all such great questions and varied questions, right? So there are certainly stages of life that are more prone to sleep disruptions. And this is true of women and men, but for women, some of these reproductive stages are exemplified by a major change in hormones throughout the body that can interrupt our typical sleep patterns, as well as our mental health overall and our overall well-being. And so it's important to recognize this as a contributing factor when we're thinking about both the sleep disruptions that occur in these phases, as well as symptoms of depression, anxiety, and other mental health disorders. So one of the questions was asking specifically about the impact of sleep deprivation on the postpartum period. And we know that there are significant links between sleep deprivation and various mental health conditions, as well as just the prognosis for those who do experience things like postpartum depression or anxiety. When they experience sleep deprivation simultaneously, they tend to do worse and have more severe symptoms that require perhaps even more urgent or emergent treatment. And so managing sleep in the postpartum period, again, as a team with the other support in your family is really, really important for kind of maintaining that stability and allowing an individual to get adequate sleep. As I mentioned, the menopausal transition is one in which we are very aware that there are a lot of sleep disruptions, but there's very limited evidence that really studies how best to treat these sleep disruptions. There is some evidence that certain hormone replacement treatments can help with the sleep disruption that comes from menopause, and some evidence that the patch version of those HRTs are slightly more effective than oral HRTs, but this is still something that's very much in development. There's also some evidence that melatonin might be a helpful supplement for people who are experiencing sleep disruption in menopause. But these are both things that you would want to talk with your gynecologist or PCP about in order to ensure that you're kind of adequately addressing any underlying conditions that might be impacted by either melatonin or HRT. The other thing to keep in mind is that even as you're experiencing sleep disruptions that may be out of your immediate control because of biological factors like hormone changes, sticking with the kind of general rules of thumb around sleep can really help. So staying active, eating well, drinking plenty of fluid during the day, making sure that you're having consistent bedtimes and wake times, all of those things still apply, even if you're experiencing sort of a natural sleep disruption, and can help you to avoid having more chronic sleep loss going forward if you kind of maintain that balance of good sleep hygiene, even as you're experiencing sleep challenges. I hope that helps.
Great. Thank you, Dr. Ragland. The other major theme that we saw in questions is the connection between anxiety and insomnia. And some of the examples of these questions include, I'm 45 and suffer with anxiety, especially at night. Will getting more sleep help my symptoms? Also, how does sleep affect anxiety in students in high school? And can you talk about the link between anxiety and sleep? And I'm wondering if Dr. Swanson can help us out with some of these questions.
Yeah, absolutely. Thank you, Dr. Conway. Yeah, as I mentioned during my talk earlier, anxiety and insomnia are very closely linked, and we very much do see a bidirectional association between these two things. I think, based on some of the slides I showed you all and some of the data that we have, we do often see that anxiety comes first, or it happens at the same time as insomnia in people who have both conditions. And sleep loss can definitely heighten anxiety, and it can make it harder to control the anxiety. So certainly we know that if you're sleeping better, it's likely that you're going to have better ability to manage your anxiety. But this can ultimately just become its own vicious self-feeding cycle. So ultimately what we recommend is, if you're someone who has a lot of anxiety and you have the sense that the anxiety is something that's keeping you up at night, that you think about ways that you can address the anxiety symptoms. And so this might be things like, getting control of racing mind, learning how to relax your mind and your body, and those things can ultimately help you to sleep. I do want to mention that these arousal reduction strategies, or strategies to help manage the kind of anxiety that we often see in insomnia, is part of the treatment package for insomnia that's called cognitive behavioral therapy for insomnia. But you can also learn them as part of an anxiety treatment and apply them in the evening as well. So I think the bottom line is that these things are very closely linked. And yes, improving your sleep is likely to have a positive impact on your anxiety. And there are tools that you can learn to help manage this.
Thank you, Dr. Swanson. One more thing, just that you're on. Some questions have come up in the Q&A just about CBT for insomnia and what it is and how it might be helpful. Could you just spend maybe 1 minute on that one?
Yeah, I'm very happy to talk about that. So that is something that we do offer here at Michigan Medicine. It is the first line gold standard treatment for someone who has chronic insomnia. And essentially it's a treatment that's focused on the the thoughts and the behaviors that we think perpetuate insomnia. So it's a treatment that's going to teach you tools and strategies that you can use to help retrain your brain so that it learns how to do better sleep and consistent and consolidated sleep. Again, it's a short-term treatment, so it's 4 to 6 sessions, and it is focused on a lot of behavior change and also taking a look at how you think about sleep and how that's impacting your sleep and giving you strategies to address uh, mental arousal as well as negative thoughts that might be occurring about your sleep that make it harder for you to sleep. So it's highly effective. 70 to 80% of people who complete a course of cognitive behavioral therapy for insomnia see improvements in their sleep. And I think one of the ways where it's more beneficial than a medication, so a medication might work immediately, but what we see with sleep medications over time is that they tend to lose their effectiveness. With cognitive behavioral therapy for insomnia, you're learning the tools that you need to manage your sleep long term. And so our long-term treatment data show that people continue to sleep well even years out after treatment. So it's absolutely something that we recommend if you have chronic insomnia.
Excellent. Thank you. And Dr. Shelgakar, you talked a lot about sleep apnea, and there have been some questions coming in about the role of sleep apnea and insomnia. Specifically, one question asks, could you talk about insomnia in combination with sleep apnea? Do you need more than one approach to sleep disorders?
This is a great question. Thank you. So we actually refer to this entity as COMISA, comorbid insomnia and sleep apnea. And this is definitely probably more prevalent than we even recognize. Sometimes we really focus on one sleep disorder and then we say, okay, now what's next? And then there are other symptoms that are still residual. And this combined entity really coexists in many of our patients. And this is an area of interest and ongoing research to understand how to best evaluate and treat this combination. But absolutely, multifaceted therapy is often needed to really help people get a full night of restful sleep. So if you are in the midst of treating your sleep apnea and you feel like there are still interruptions to your sleep, still difficulty falling asleep or staying asleep, then it's certainly worth talking with your healthcare professional about to see if there's adjunctive or additional treatment that's needed.
Wonderful. Thank you, Dr. Shelgakar. Now, a lot of questions have come in about medications and specifically how the medications are affecting people's sleep. And I'm going to read out one of the questions that represents other questions, not only about the use of medications, but the experience of waking up in the middle of the night and being wide awake and unable to return to sleep. So an example of this question is, I sometimes take Ambien when I can't fall asleep. However, that makes me wake up around 3 a.m., which isn't enough sleep time. Are meds really any help getting to sleep? I'm wondering if Dr. Ragland could take a stab at this, and then we'll open it up to anyone else who'd like to share.
Sure, I'd be happy to take a stab at this. So sleep medications often do help us sleep. I mean, they can make us either feel sleepier or they can make us feel less agitated, depending on what kind of medication it is that we're talking about. And for short-term use, like when somebody's experiencing an immediate stressor, or if they have, a medical condition that's making it harder for them to sleep for a short period of time, they can be really helpful tools to get somebody back into their usual sleep routine. That being said, there are no sleep medications that are really indicated for long-term consistent use. And so if you're experiencing insomnia, either where you're waking up too early or you're not able to fall asleep or you're awake for ages in the middle of the night, it's probably not a problem that's going to be best solved by medication in the long term, because the medication tends to mask those symptoms rather than actually helping you to develop coping strategies and tools to better manage the symptoms and create a better sleep sleep consolidation in the long run. So our typical recommendation is that, again, sleep medications can work for, periodic sleep disturbance or short-term disruption in sleep. But for longer term insomnia or sleep disruption, we would recommend cognitive behavioral therapy for insomnia or behavioral management of those symptoms.
Thank you, Dr. Ragland. Another question coming through the Q&A says, suggest guidelines for common mistakes when taking melatonin to help sleep. Dr. Swanson, would you like to take that one?
Yeah. Melatonin is interesting in that the time at which you take it can really impact what it does for you. And also, it's interesting in that really small doses of melatonin taken. So if you take a small dose of melatonin, it ends up producing levels in the brain that are much higher than what the brain naturally does. I want to mention here that melatonin is not indicated for insomnia. Unfortunately, our data suggests that it doesn't really work well for insomnia. But if you have jet lag or a circadian rhythm sleep-wake disorder, like Dr. Shelgakar was speaking about, melatonin can be helpful in shifting the clock. And I won't go into too much detail about that protocol here because it's sort of involved. But I will say, I think the bottom line for us as behavioral sleep medicine providers is that unfortunately, melatonin doesn't really work well for insomnia. And we only want people to be taking it if they're looking to shift their circadian clock. And I guess ultimately, I know Dr. Ragland had mentioned use of melatonin in menopause. So I guess I am going to give some specifics here, but if you really do want to try it for something like insomnia, what we recommend is a low dose, so between 1 and 3 milligrams taken within an hour or half an hour of bedtime. But again, it's unlikely to make your insomnia better.
Excellent. And maybe I'll read one, maybe two more questions, but again, on the topic of difficulty staying asleep. So examples of questions like, how do you overcome the sleep pattern or habit that gets you up at 3:30 a.m. for an hour or two? Or how do you get back to sleep when awakening in the middle of the night? Or what is the best thing to do for those constantly waking up in the middle of the night and can't get back to sleep? Dr. Shelgakar, do you want to start with this one?
Sure, and then I will turn it over to you too, because I know we have many mutual patients where sometimes we are, working as a team to try to get to the bottom of what may be underlying these multiple wake ups. So, we try to take a broad approach to really understand all the factors, and it's different from one person to the next. So for some people, it may be untreated or suboptimally treated obstructive sleep apnea. For some, it may be chronic pain. For some, it may be anxiety or depression. For others, it may be caregiver responsibilities. Or, of course, life being life, it could be multiple of those things all convening at the same time, right? And so I think the first thing is to have an evaluation and really explore what are all of the potential contributors that may be influencing the likelihood of having those repeated wake ups, even if they are distributed across the night or if they seem to be time stamped at a specific time of night, to see, once we have a better understanding of what are those factors, then how can we more deliberately address them and try to get to the bottom of them so you can have more consolidated and more continuous sleep. So I would say it's a combination of both needing a medical evaluation and then in partnership with our behavioral sleep medicine colleagues, like my three colleagues here today, to really understand everything that may be contributing. Dr. Conroy, if you have something additional to add from your vantage point.
I would like to echo that it can be multifactorial, and utilizing some of the strategies that Dr. Swanson had also mentioned about calming the mind or relaxation strategies, or learning what thoughts are waking you up in the middle of the night with a mental health provider can be really helpful in the process of returning to sleep. Anyone else have anything to add to that? Okay. Maybe one more question and then we'll start to wrap up. Question, is it a good idea for someone suffering from treatment-resistant depression to get a sleep pattern check? Dr. Swanson, do you
Oh
want to
yeah,
start with
so
that?
I had answered this in the chat, and I think now that I'm thinking through, I would recommend that you do talk to your primary care provider about your sleep and the role, and your psychiatrist, if you have a psychiatrist, about the role that your sleep may be playing in your treatment-resistant depression. I do think it can ultimately be helpful to screen for sleep disorders like insomnia or sleep apnea, which are linked to treatment-resistant depression. So I definitely think it's worth talking to your doctor about.
Excellent. Well, at this point, we're going to start to wrap up. I want to have everyone get a chance to provide some closing remarks. So thank you all for joining us at this event. But before we finish, I want to open it up to our experts to give any closing thoughts or remarks. Dr. Shalgakar, we'll start with you.
Sure. I just want to say thank you all for being here. It's really exciting to see how many people care so much about sleep and healthy sleep. And so, keep reaching out to your healthcare professionals if sleep is a concern, because there are so many things that we can do to evaluate and address difficulties with sleep, because it really is such an important part of our overall health and well-being.
Dr. Swanson?
Yeah, I just want to echo what Dr. Shalgakar said. We're very glad you're here today and thinking about sleep and ways to improve sleep. And there are lots of us experts here in sleep at Michigan Medicine who are really standing by to help you sleep better if you're not sleeping well. And then I do want to give a plug for our research studies as someone who does a fair amount of research, that we have research studies that are ongoing here at the University of Michigan that are focused on sleep or sleep and psychiatric conditions. So if you're interested in research, I recommend that you please check out our U of M Health Research website, and I will put that link in the chat as well.
Thank you, Dr. Swanson. Dr. Ragland?
Just echoing the thanks for being here. It's so wonderful to have such an engaged group of folks to talk with today. I think the overarching thing that I would like people to walk away with is that sleep is something that can positively impact mental health overall. And also, if sleep is suboptimal, it can be a challenge in overcoming other mental health concerns. And so if you have any concerns about your sleep or feel like it's something that could be managed better, we are here to help. And your other providers may also be able to offer opportunities for assistance. So please don't hesitate to reach out to your medical providers or mental health providers to see if you can get your sleep in a somewhat better position, so that you have more energy and resilience to affect change with your mental health as well.
Wonderful. Thank you all so much. Thanks so much to our presenters for their insights, and thanks to all of you for tuning in and asking such thoughtful questions. We hope that you found this presentation informative. If you're interested in making a gift to support any of the sleep-related research that's happening here at Michigan Medicine, please reply to the follow-up email that we'll be sending out in the next few days. So thank you so much for joining us. I hope you have a wonderful rest of your evening.